So the topic one protocol is comparison of PD-L1 expression by various IHC assays in advanced non-small cell lung carcinoma and its correlation with various treatment outcomes. So a little bit of background. So immune checkpoint inhibitors have dramatically improved the treatment of advanced non-small cell lung cancers. And various PD-1, PD-L1 inhibitors are used based on the clinical factors as well as the PD-L1 levels, which are expressed by IHCs. However, each immunotherapy drug which is approved for use is again tested along with a companion assay. So although PD-L1 expression is not the perfect biomarker, the different IHCs of the PD-L1 expressions have had a major impact on the clinical development of PD-1 and PD-L1 checkpoint inhibitors. So the problem arises is that it's not feasible to check the PD-L1 levels by the different diagnostic assays to their companion drugs due to the lack of availability at each center and the cost barrier. A recent systematic review observed that the intra-assay agreements of the tumor cell staining is high between the standardized assays, that is 22C3, 28A, SP263, and SP142 showed a slightly lower staining. There have been some studies which have shown an even lower concordance levels with the use of clinically relevant cutoffs. This becomes significant at the cutoff values, especially the 1% cutoff, which may lead to a higher disagreement when compared to the 50% cutoff values. Few studies in the real world have studied the outcome of the immunotherapy treatment and correlated the same with different assays used. Most of this has been in the clinical trial setting. Other factors like neutrophil to lymphocyte ratio, that is NLR, and derived neutrophil to leukocyte minus neutrophil ratio, that is derived NLR, are also seen associated with the PD-L1 immunotherapy response. So the use of different assays with their non-companion drugs may alter the expected response in patients which are being treated. This might be due to the discordance in the PD-L1 score as checked with one assay when compared to the prescribed companion diagnostic assay, which is more likely at a PD-L1 percentage which is nearing the cutoff at various indications. So we hypothesize that the patients who did not respond to the immunotherapy would have had a slightly lower PD-L1 score by the tested assay as compared to the companion diagnostic assays. And patients with PD-L1 positive expression sometimes also do not respond as expected, which further leads us to expression of various other factors like neutrophil lymphocyte ratio and derived neutrophil leukocyte ratio, which may also play a role in response. So our primary objective is to study the expression of PD-L1 by IHCs by the different assays, that is 22C3, 2263, and SP142 in advanced non-small lung carcinomas, and to find the sensitivity and specificity between the different assays with the companion diagnostic. Our secondary objective includes the study of the treated patients with the anti-PD-L1 therapy and assessment of their clinical response, which is assessed after 3 months of initiation of therapy, as responders or non-responders, and see the association, if any, with the percentage of tumor cells staining. Our tertiary objective is to study the clinical response in patients with respect to various factors like baseline NLR and derived NLR. So this will be a retrospective study in which the study population will be composed of patients who have advanced non-small cell lung carcinoma and who have received anti-PD-L1 immunotherapy as part of the treatment regime at HBCH MD Varanasi from July 2019 till start of the study. So the study will be covered over a period of 2-year duration. The inclusion criteria includes those with advanced non-small cell lung carcinoma treated with PD-L1 immunotherapy drug as first-line therapy. All those cases for which blogs as well as slides are available for review. And for each biopsy, there should be a minimum of 100 viable cells left in the keratin block for analysis. The exclusion criteria includes the non-compliance to immunotherapy, which is checked at 3 months' time. So this is just a brief overview of the methodology that I'll be following with the time period on the right side. So I'll start with the keyword searches in the AMR for advanced non-small lung carcinoma patients who have been started with PD-L1 immunotherapy during the time period. Only the cases where immunotherapy was used as first-line drugs with compliance and follow-up data present will be included. The initial relevant histopathology and ISC slides and keratin blocks will be retrieved. Cases meeting the inclusion criteria, they will be then studied further. So for this, first the ISC part comes in place. So the tissue sections will be staged with the relevant assays, and the results of the staining will be expressed as percentages of the tumor cells which are stained positive as evaluated by two pathologists, and they will be recorded accordingly. Meanwhile, details regarding the response will be assessed, and the response will be defined as partial complete response by RECIST 1.1, after a period of 3 months from initiation of therapy. And furthermore, this response will either be graded as a responder or a non-responsive patient. Also, baseline NLR and derived NLR will be evaluated for each patient from the EMR, and the results will be recorded and analyzed. So our statistical analysis plan, so the projected sample size, as of now, the exact sample size calculation is not performed because this is a retrospective analysis of all the data. But the projected sample size that we are having right now is about 100 patients. So we'll be calculating the sensitivity and specificity for each non-companion diagnostic assay with the companion diagnostic assay, and the concordance between the assays will be evaluated. The overall percentage of agreements will also be determined according to 1% cutoff and 50% cutoffs. Furthermore, association between the response and percent of IHC expression in the tumor cells also will be explored. And in order to define the cutoff values for NLR and derived NLR at baseline predicting response at 3 months will be calculated using the RFC curve. So coming to the future implications, this study will help in assessing the interchangeability of the different assays in resource-limited settings, which can help in better confidence in initiation of the therapy with the anti-PD-L1 immunotherapy drugs. This will also help guide clinicians regarding the decisions about use of immunotherapy in relation to PD-L1 expression, especially in those cases where there's borderline cutoffs for a particular specific indication. And factors like NLR and derived NLR in conjunction with the PD-L1 levels may also help to predict response in patients before starting off immunotherapy. So I would like to acknowledge Department of Pathology, Department of Medical Oncology at LBCH and Varanasi. I would also like to acknowledge all the help and inputs I have received from my mentors in the Aspire team. Dr. Vikram, Dr. Reema, Dr. Tejpal, and Dr. Mahesh. Thank you so much for all the inputs and suggestions. Thank you.